Good morning, everyone. Congratulations to Dr. Banga and his team for organizing this wonderful meeting. I'm really sorry that I'm not well and I'm unable to be there physically. So my journey as a robotic surgeon is not exactly the same as you are seeing in this video clip. It's not like this at the current moment. Maybe someday in future it might be. So my journey started as a general surgeon in 1988 when I qualified from Maulana Azad Medical College and associated Loknayak Jai Prakash Hospital. So there I built expertise in traditional open surgeries, focusing on patient care and outcomes, and developed a strong foundation in anatomy, surgical principles, and complex cases. Subsequently, what we did all realize that open surgery had its own problems, whereby you had to cut muscles, it caused pain, etc. I don't need to go in through this list. And following this came my journey with minimal access and laparoscopic surgery, which began in London in 1992 at Charing Cross Hospital and Medical School. And there we started laparoscopic surgery, laparoscopic gallbladder surgery. At that time, unfortunately, these were the kind of articles that used to come in the journals: threat or opportunity, milestone or dangerous innovation, etc. And we all know now that minimal access surgery is the preferred method for cholecystectomy and similar abdominal surgeries. So laparoscopic surgery did have its limitations. While it was good for lap chole, advanced cases were a problem. We needed an assistant active arm. Camera control could be having issues. 2D vision, non-intuitive movements were all some of the problems faced. The instruments' angles were restrictive. They couldn't move, they couldn't bend. So as to always wish I had four arms. So if I ask you a question, can you control a machine with four controls by hands, three by foot, three places to look around, and while doing all this, you can also chat? So many would say this sounds like a difficult proposition, but what I'm talking about is driving a car, nothing more complicated. And we all know that after a while, we are all able to drive a car with your foot going in three places, because God has given us human brains and adaptability that we are able to learn things pretty fast. However, history of mankind has always been against new innovations. We saw this during laparoscopic surgery, where there was a lot of opposition. So similarly, there is opposition when it came to robotic surgery. So this is a small video I'm sharing, and this is a totally robotic bariatric surgery which you are seeing in a 270 kg patient. The surgeon sits here at a console, and this is the Da Vinci Xi system. And this console means we have a place to first log in, feed in our details. There are personal settings. You can see the foot pedal moving up, forward, backward. The armrest moves according to your choice. So does the headrest movement up and down, as well as angulation. Control of instruments take place through these finger controls, where the thumb and middle finger have gone inside. And these fingers will control instruments inside the abdomen in a wristed way. Foot pedals for energy sources, right instrument, left instrument, cautery cutting. Then we have a camera pedal, we have a clutch there, and we also have a pedal to switch between instruments. This is what the instruments look like. So that's a robotic trocar, not very different from a laparoscopic trocar. And you have the robotic instruments. And if you can see there, the tip and the finger of these instruments are able to move in 360 degrees, as opposed to human fingers, which only move in one direction. So this is what gives a lot of versatility when it comes to instrument moving. This is the patient being prepared. And after that, we would put in a Veress needle. to insufflate the abdomen. That's a robotic cannula which has been introduced. Through this, we would be putting in a telescope. What is interesting, if you note, we don't need any steep head up positions when doing bariatric surgery, because it's the robotic arms which are going to lift the abdominal wall and give us adequate space. So you can see there is hardly any tilt of the table in this 270 kg patient. So anesthetist is very happy with such things. And now you can see the robot which has been wheeled in is being brought to the head end of the patient like that. The robotic arms will then be connected to the cannula, which is known as docking of the robot, as you can see there. And this is what our robotic theater looks like after the surgery has started. Then we also have some special instruments which we use during surgery, and that's the surgeon sitting at the console with the instrument moving inside the abdomen. This is a robotic stapler which has a degree of artificial intelligence in it. It can sense the thickness of the tissue and guide us as to what color cartridge should be used, and also automatically compresses the tissue as per the requirement based on the thickness it is able to sense. So that's the robotic stapler that has gone inside. And you can see we'll have another clip on the robotic stapler in a while. And this is the articulated stapler, which is gauging the compression thickness and it fires by using artificial intelligence. It's very firm in the grip. You can see the stapler does not move a millimeter here and there when firing. It's the firing completed. So this is how the surgery is taking place with the instrument control by the surgeon at the console. So this is the patient. He had his own special jeans made. After 6 months or so, the kind of weight he lost, and he's still wearing the same jeans. About 1.5 years later, this is him in the OPD. At this time, he had to buy some new pair of jeans. So what are the notable milestones I have faced in robotic surgery? In 2012, I started with fundoplication, rectopexy, thymectomy. In 2013, I also started doing bariatric surgery by robotics, abdominal wall repair in 2015. So first time globally, I have the honor to have done certain surgeries: the robotic MGB OAGB, robotic thymoma of a large 500 grams thymus, robotic pancreatic surgery, robotic hepaticojejunostomy in benign strictures, and robotic TARM for ventral incisional hernias, which was also telecast at IAGS meeting in 2018. So this is our publication with the robotic 1 anastomosis gastric bypass, the first in the world. Also the robotic hepaticojejunostomy. Our hernia series still under publication. So why do I prefer robotics? Better dexterity, and because of better dexterity, we have reduced technical errors, improved anastomotic integrity, and lower complication rates such as leaks or strictures. Then we have improved visualization because of the 3D immersive view. And this can lead to fewer injuries to surrounding tissues, reduced blood loss, shorter operative times, which contribute to overall patient safety and outcomes. We also have improved ergonomics because the surgeon can sit at the chair, as you saw in the video. Increase surgeon focus and precision over extended period, potentially leading to better surgical outcomes and lower complication rates. Then we have a shorter learning curve. We found while training our juniors, and even when I switched, that the learning curve for robotic surgery is much less than other learning curves because of the superior technology. So new surgeons may achieve proficiencies more quickly, which can enhance the overall safety and efficacy of the procedure and reduce long-term training costs. The precision and fulcrum ergonomics of robotic surgery leads to less trauma to surrounding tissue, resulting in less post-operative pain and faster recovery. Now, this is a question which a lot of people ask, that in laparoscopy you have 5 millimeter ports, here you have 8 millimeter ports. How can you say that the pain is less here? And that happens because of the fulcrum effect, because the instruments, they would move through a fulcrum and there would be no side to side or up and down movement of the trocars and cannulas, thereby reducing the amount of bruising that can take place in the abdominal wall muscle. And this continuum concept on the abdominal wall is what leads to less muscle trauma, less bruising, hence less pain and early recovery and early discharge. Then the indications also increase. So, for example, super obese, and the best example I can give here is that a lot of surgeons who would hesitate to do complex procedures laparoscopically are able to do the same procedures robotically. So it basically raises the standard and makes an average surgeon do advanced surgeries with the same proficiency as the more skilled surgeons. So it reduces the difference between a highly skilled surgeon and a relatively less skilled surgeon by giving them the platform whereby they can do better surgery. There is this My Intuitive app, and I've been doing this surgery since 2012. And what you can see here is that this is one example of a procedure, and where this is a sleeve plus operation where we did a sleeve gastrectomy with a bypass. And you can see that total surgery time was around 50 minutes with active time of 34. Now, this is a surgery which, if I am asked to do laparoscopic, I would not be able to do in this much time. In other words, what I'm trying to say, that after the learning curve, we are able to do surgeries much faster robotically. As you can see, at another example, this was in 2022, you can see, when my surgery time of robotic bypasses became much less than that of the laparoscopic. And you can see in 33 or 40 minutes, 42 minutes, we are able to do gastric bypass surgery. The app also tells us about the timeline and what all instruments were used. So just to give an example, we also did a study of 30 cases by laparoscopic and robotic surgery by the same surgeon, which is me. Induction to start of dissection, time taken for pouch formation, time for the GJ, and time taken to extubation were 4 steps. And we will see, this is how the robotic anastomosis is being done. So that's a pouch which has been opened, the stomach pouch, and here we've got the intestine. And this end-to-end anastomosis, end-to-side anastomosis, which we are doing, can be done much faster by robotics than by laparoscopic. At the same time, we can visualize the vascularity by using the indocyanine green, which is known as Firefly technology. Cornell stitch for the corner. This is a gastric tube being passed across the anastomosis. You can see the front hand, back hand, side hand, all sorts of movements which are possible with that needle holder to be able to get a good anastomosis fairly rapidly. Final look. We also do a methylene blue leak test in all these anastomosis. That's the anastomosis. This is the Surform stapler which I was talking about. And here you can see how the instruments can move in various directions, rotation, angulation in all directions. So it acts like a good grasper as well as a stapler. And here we are using it to form the pouch. If you see number 1 at the bottom left of the screen, that is what the stapler is showing. And when it is clamped, it becomes blue. You can see the clamping being done and the firing, which we saw earlier also. It's totally steady without any movement with excellent hemostasis. So another criticism is about the time taken. So this is an SI robot, and this is a video which is about 10 years old. And you can see that's the SI robot being wheeled in. There is a clock there where you can see the timing. That's the robot being docked. And people talk about a lot of time being spent on docking. But as I say, that once the team is familiar with the robot and after the initial learning curve, the docking should take very little time. And here, as you see in this video, the entire docking has been completed in 45 seconds. So going back to the study which I was talking about, the step 1, step 2, step 3, and we've done a statistical analysis. This graph chart will tell us what exactly we found. Now, the step 1 and the step 4, the robotics took a little longer, which is the yellow, but for step 2 and 3, robotics actually took less time. So the total operative time in a gastric bypass surgery done by me is less than the time I would take in laparoscopic. There are newer robots which have come in the market and also under development. And the most important aspect which currently is being worked out are what is known as a single port robotics, where all the instruments would go through a single cannula, go inside the abdomen and move around by our controls. Like that, as you can see there. So all movements of the camera instruments would take place through the robotic arms there. Then we have Made in India robot, which is the SSI Mantra. I'm very proud that we Indians have developed this wonderful technology of robotics, and there are many benefits of the SSI Mantra over the existing robots of other companies. I'm sure this is something which will be covered by other presenters in this meeting, where SSI Mantra would be talked about. There are quite a few installations which have taken place in India, and surgeons have been very happy with it, and a lot of good work is being done using this robot. So to conclude, I would like to say, I'm not ready to say that robotic surgery is the future for our field. It's a good fit for specific procedures, but not for all. However, using computer technology and advanced imaging to improve what we do for patients is absolutely the future of surgery, and the current generation of robotic devices is the very beginning of that revolution. So it is entirely up to us. The robot is here, what you use for, whether you use it for Aarti, as you see on the left, or whether you use it to open a beer bottle and pour beer, as you can see on the right. That is your choice. It's a tool. And my last comment would be, change is inevitable, growth is optional. With that, I come to the end of my presentation. Thank you very much for listening, and apologies again for not being physically present to attend this wonderful meeting that is being organized. Thank you very much.